Hey, it's me, Jen again, and today we're meeting the first Thyroid Rfa provider in the state of North Carolina. We'll be joined by Dr. Kirk Faust after this. Welcome back to the Surgeon Series. Today's guest has been exclusively an endocrine surgeon for nearly 2 decades. He was intrigued to learn about how Thyroid Rfa could achieve similar goals to endoscopic thyroid surgery in a much simpler and less invasive way. You're a surgical endocrinologist, correct?
That's correct.
Or surgical oncologist?
No.
No? Okay.
Right. So my training is in general surgery. So back in the days when I trained, there weren't really fellowships, and most people just did general surgery.
Mm-hmm.
Part of general surgery is thyroid surgery and endocrine surgery. And then there was a time when I did do a lot of surgical oncology. About 20 years ago, I was sort of overwhelmed. So we hired a fellow to take over my practice of oncology. That led me to focus on to endocrine surgery, which is kind of what I wanted to do. I've been doing just endocrine surgery for about the last 18 years or something like that.
So you've really got a great deal of experience in endocrine, which is very important for someone who's going to be undergoing surgery.
It would be hard to find anybody in the United States that has done more endocrine surgery than me. And I say that,
wow.
well, I say that not because there's not a whole lot of people that do a lot of it, but I've done only endocrine surgery for almost 18 years. And it's not that you couldn't find somebody else that has similar experience. A lot of the guys at academic centers that do only endocrine surgery, that's all they do, but they leave town a lot and they go to meetings and they do a lot of other things. And all I do is operate every day, all day long. And that's not to say that I'm the best endocrine surgeon. I'm just saying, if you're looking for experience, I'm your guy.
That leads me right into my question then. Why Thyroid Rfa? What on earth would make you as a surgeon consider offering a non-surgical procedure?
There are times when the problem is simply a structural issue that bothers the patient. Mm-hmm. It's not cancer. Maybe the local symptoms aren't overwhelming, but you can project in the future that it'll be a bigger problem later. So somebody who's young with decades of life expectancy and has a big structural issue, they're kind of only left with surgery, which is fine and works very well. Even though it's outpatient surgery and people do very well with it, still surgery. But more important than that is if you take out a portion of somebody's thyroid gland, then there is a real possibility that they may have to be on thyroid medication. Now, that's not the end of the world. But not everybody does well on thyroid medication. Most people do. Maybe they started doing sort of remote access thyroid surgery 10 years ago. It became sort of popular in the United States. I actually went overseas and looked at it and thought about doing it in my own practice. For a lot of reasons, I thought remote access thyroid surgery, it bothered me in a lot of ways. Now, what I mean by remote access thyroid surgery is where they go through the armpit or through the mouth to try to take part of your thyroid out. And that does work, but it's really not a very good technique for malignancy. And you can't do it in big nodules. So it's a pretty limited number of people that can have it done. Its only advantage is the lack of a surgical scar, but it's really extraordinarily invasive to avoid the scar. Because if you're very careful with the scar, you can make it look pretty good. I kind of felt like that remote access surgery was kind of a gimmick. I saw radiofrequency ablation offering it to patients who really didn't want to have surgery. They were worried about the scar. More than anything, they wanted to sort of avoid that experience. So I got interested in it because I saw it as an alternative to that kind of approach. And it was much more simple, and it gave the same outcome that people wanted. So I thought, wow, this looks perfect for that. So, I mean, most people want to avoid surgery if they can. And if you want to just deal with the structural issue, I think it can be a pretty effective technique. It's not perfect, but I mean, I can be.
No procedure is.
Right. So, but I think it's a good thing you can offer people for the right person. Sorry, I tend to be long-winded.
No problem. I love a good explanation behind somebody's thinking because it really gives you kind of a glimpse into what your priority is and what your motivation is. And, for me, RFA, the big motivating factor was that I am a poor surgical candidate. When I was younger, I had a really horrible outcome from a couple of knee surgeries. I had staph infection that was systemic, nearly deadly. So I was told by a specialist a few years later, you should never have any surgery again, unless you're dying. So when I ended up in a situation where I had a pretty massive mass on my neck, and I was sent to an ENT, and he says, well, you need to have this taken out. I'm like, can't do it. I thought, okay, what am I going to do about this thing? I guess I'll just have to keep living with it and hope that medical innovations will catch up to me, Right. And then I ended up having an allergic reaction to some antibiotics a few months later that caused my nodule, it hemorrhaged into itself. Oh, so wow. It rapidly expanded. It went from about 45 milliliters to between 65 and 75 overnight.
Oh my word.
Which took me from being, I'm living with this thing, to I have to do something now. And so I was very fortunate, blessed that I was able to access RFA at that time. It was in July of 2019. And at that time, there were only 2 providers in the US. Yeah. And I drove all the way from Alabama to Virginia to have my procedure done. Where you're located at UNC Rex in Raleigh, the nearest locations to you are Atlanta, Georgia, Louisville, Kentucky, Baltimore, Maryland, and Charlottesville. But that location's actually about to go away because that doctor is actually relocating to Texas. So, which is my doctor. Oh, so anyway, so it's really exciting to me and to a lot of patients that you are now doing this in North Carolina, because as I was saying, I drove a long way to access this. I'm not the only one. In our Facebook group that currently is about 3,000 members, we've got patients from all over the country, all over the globe, and they're asking, where can I go access this procedure?
That's amazing, because I'm not on any social media.
Well, you don't really have time. I mean, you're a busy guy.
Yeah, well, that's true too. Yeah, wow, 3,000 people.
So after I had my initial procedure, I felt like I just needed to share with people that this was a thing, because I had found the information. I had really had to dig for it on the internet. It was not easily found. And so I created this group, and it's just grown and grown and grown. People are very excited about this procedure. And frequently there are people in our group from North Carolina saying, is there anyone in our state doing this? And I'm so thankful now to be able to tell them that you are. And I would love to know how you got this brought to your facility, because I know you work with a really kind of a big hospital system, right?
Even though I'm affiliated with UNC, I'm really separate from it. I'm really just an employed physician. But I was in private practice with a group for many years. And then about 10 years ago, it really became apparent that private practice was going to be a difficult road to hoe. So we joined with another group of surgeons, and then we sort of had a choice of joining with the health system that Duke runs or the health system that UNC runs. And for a variety of reasons, we chose UNC. We were affiliated with them for several years, and then because of some legal issues, the federal government required that we become employees. So now I'm an employed physician at Rex Hospital, which is in Raleigh, owned by the University of North Carolina School of Medicine. I'm affiliated, but I'm not an academic guy. I don't have any teaching responsibilities. So I'm sort of really just in private practice. So
okay.
Because of that, and because I have a very large practice, our practice is a lot more nimble in our ability to incorporate new techniques and new things. We don't have to go through bureaucracy that a lot of academic institutions have inherent in their system. We were able to say, this looks like a good idea. Let's go find out about it. Let's get trained. Yeah, let's do it. And we could make it happen reasonably quickly.
I'm sure COVID played a role in how slow
Absolutely. Our hope was to actually do this over a year ago. But right when we were getting ready to pull the trigger on it, that would have been February of 2020. And as we started looking at different possibilities, then COVID hit and everything became a problem.
And that is very common. I've talked with so many other doctors that have said, yeah, we were ready to do it, and then COVID kind of messed up our plans. And I'm hoping that maybe now we're kind of starting to maybe get out of that holding pattern, and maybe we can start moving forward again. I mean, as evidenced by the fact that you're now doing this. And so tell me a little bit about your training experience. Did you have to travel, or did someone come to you, or how did that work?
No, we initially were contacted by somebody, I think in Nevada, that was selling the machine, and they had training. And then ultimately, guys that we ended up with were a little bit more organized and more sophisticated in their sort of approach to training and things like that. So we talked to them, and then they put me in touch with Dr. Turfano, who is an ENT surgeon at Johns Hopkins. I went to one of his courses, and we practiced on models and cadavers and things like that, and learned the technique and researched it and read about it. Spent a lot of time reading about it, watching videos. Then I went to Louisville to watch somebody do it for a day. And he did a couple of procedures so he could see exactly how they set the room up, all the nuts and bolts, the practical aspects of it that aren't always there when somebody sort of gives you a didactic follow-up from it. I don't know how many fine needle aspiration biopsies I've done in my career, but it's literally thousands. So it was a pretty easy learning curve to kind of transition from needle biopsies using a lot of the same techniques that I've used my whole career to sort of subtly adjusting it for radiofrequency ablation. It's not really been a difficult learning curve. Basically, just a whole lot of fine needle aspiration biopsies on one person. So it's multiple passes, but it's the same technique. And, you know, it's a little different. The needle's a little bit bigger. It's not quite as sharp. The dynamics a little different, but it's very, very similar.
Awesome. Well, what has the response been like? Have you had a lot of candidates for this so far?
Yeah, it's been pretty good. I haven't been advertising it because, first of all, I wanted to do people and have time to have follow-up. We were having the outcomes that I expect. So we've only been doing just a few a month for the last several months, and usually just once or twice a month right now. By intent, we've been going sort of slow with it. But so far, our results have been very good. People have been very enthusiastic about it. It's not for everybody. As you well know, you can't be scared of needles. You got to be willing to be awake. There's a commitment to being still. And plus there's an expense, right? Because it's, at least to my knowledge and around here, it's not covered by insurance. So there is a financial commitment that you have to be comfortable with. I would say of the people that I think are candidates for it right now that I see, I would say probably about 1 in 4 maybe ends up doing it. And most of the time they don't do it because of financial issues. I think there is a certain number that don't want to have to worry about the idea of, well, it's not immediate. You got to wait for it to resolve. There's a period over several months where it shrinks. For some people, surgery is like, it's done. Plus, as you know, when you do RFA, particularly in bigger nodules, it doesn't disappear completely. There's still some residual stuff. And when you tell people that, they kind of go, it's still going to be there. And so some people kind of don't like that aspect of it too. I think when you give people full disclosure about everything that's good and everything that's bad about it, first of all, you get a more educated patient, but you don't have sort of unrealized and unfulfilled expectations and disappointment. I haven't been doing it long enough to know how many of my patients are going to need another application. But if you read people and talk to people that have done it for a while, there's a certain percentage of people that it doesn't do everything you want it to do, and you have to have it done again. Well, that's another out-of-pocket expense that not everybody's enthusiastic about. A certain number of people are going to pick surgery over it. And then I had 2 patients today that are perfect candidates for it, and they both just wanted to watch it.
Regarding having to have multiple treatments, that was actually my case.
Yeah.
I had to have 2 procedures. The first one was in July of 19, and then I went back in March of 2020. So like literally right before everything shut down from COVID, because part of my nodule was very low behind my collarbone. And at the first procedure, he was only able to treat 80% of it. So Over time, that upper portion shrank and it drew up that lower portion to a more accessible area. When I went back and had that second procedure done, it was up where he could reach it and he was able to treat all of it. And as of this summer, when I had my last follow-up in June, my nodule has reduced 90%.
Wow.
So
That's
it's
great.
been a tremendous outcome for me.
Yeah.
I've been
Well, I'm glad
very
you said that
pleased.
because I was going to ask you what your experience was. The ones that I've done, I think we've had very good results so far, but I haven't seen anybody that's out 9 or 10 or 12 months yet. That's interested to hear what your experience was.
Yeah, and we've got patients in the group who have had really great experiences too. There's not been very many who haven't had good experiences. And one thing you didn't mention that I think is the biggest motivating factor for patients is not needing to take thyroid medication afterwards.
You're right. And I always mention that. I think that's a big plus. And that's one of the reasons I think that it can supersede other surgical techniques. I think once radiofrequency ablation becomes more mainstream and a lot more people are doing it, and certainly when insurance companies start paying for it, I think that remote access thyroid surgery goes away and people won't be doing that anymore.
You think this is going to maybe take over that area?
Yeah, I really do, because the thing that motivates people for remote access surgery is not having a scar. But radiofrequency ablation accomplishes the same thing. The remote access has a variety of disadvantages in that you go through your armpit or your mouth. The mouth, not as much, but armpit really can give a lot of extra difficulty and comorbid stuff. And the recovery's not as quick. I think radiofrequency ablation will probably take the place of a lot of unilateral benign thyroid disease and smaller stuff that really is sort of the wheelhouse for remote access surgery. Whether or not it'll be effective for people with really big goiters and things like that, I think that remains to be seen. I've done one patient like that, and we did her because she wouldn't do surgery. And I was a little hesitant to take that approach with her because I was worried that it would not give her the outcome that she wanted. And also, you don't know the durability of that in somebody with a really big goiter. And you can make it smaller. That may look good for a year or two. But then if it comes back, I mean, you kicked the can down the road, but you certainly haven't been definitive. And then I was also worried in her that she would require multiple applications, which would be very expensive. And she would get into that over a period of a couple of years and then go, well, I spent all this money and I still got this problem. I mean, it's better, but it's not gone away. That's not to say that people around the world haven't had good experiences in treating big goiters with it. And that may be something that turns out to work very well. I'm just a little hesitant to recommend it. I mean, you need to know if it's a good technique for that. You need 10, 15, 20 years of follow-up. I don't think anybody has that.
Does the Asian data not have enough long-term efficacy data?
They have long-term data, but not for big goiters that I'm aware. There may be more information along those lines. I'm just not aware of it. As it becomes available, I mean, I'm willing to change my mind about it. It's not that I don't think that you should be doing big goiters. It's only that I am concerned you could get into the procedure, multiple applications, a lot of money, go down the road several years, and then it's really not what you'd hoped it would be. That may not be true at all. I don't know. But given that I don't have a good sense of that, it's hard for me to be excited about treating somebody with a big goiter when I don't really know that long-term result. I mean, I think short-term stuff is easy to come up with. Does something work for a year, 2 or 3 or 5 years and stuff like that? And the answer is a lot of things work. What you're looking for is something that's durable for their whole life. I think so. That's just me.
That's completely reasonable. And I think my understanding, and granted, I'm a layperson, so I will not contend with you on your knowledge
you
all.
Probably know a lot more about this than me.
My understanding, and this is from hours of talking with my doctor, who was trained directly by Dr. Baek in South Korea, is that as long as it is treated as completely as possible, my understanding is that you can't go outside of the capsule of the nodule, but you can go as close to it as you possibly can, that as long as you have eliminated almost every bit of viable tissue, that there's not going to be any recurrence. That when you have recurrences in these larger nodules, it's from that remaining viable tissue. And when I saw him this past summer, I was concerned about that. I said, do I need to have a third procedure? Because I really don't want to unless I really need to,
Right.
because I mean, like you said, it's the expense. It is a medical procedure. And he said, no, the amount of tissue, viable tissue that's left in your case is so small and you're not having symptoms. I don't think that there's any risk of it recurring, at least not right now. And so my plan and with my doctor is to follow up once a year with him to keep an eye on things. And if, say, in a year or two, it looks like, oh, maybe there's been a little bit of regrowth, we'll handle it then. But at this point, with 90+% reduction, I'm in good shape and I'm happy.
Yeah, absolutely. I agree totally. Obviously this is designed, and what it's approved for is benign thyroid disease. When you get in a situation where you have multiple nodules, a lot of diffuse overlapping structural problems, you can believe that you're dealing with something benign, and most of the time you are, but there's a possibility that you're not. So my enthusiasm for treating things that aren't clearly, unequivocally, no doubt about it, benign is less than somebody else. Now, as I gain experience and things like that, I might change my mind about that. But if you're dealing with somebody who has a lot of overlapping nodules, you've biopsied the big ones, and it all looks okay, there's going to be a small chance that there could be a hidden cancer in there somewhere. Post-ablation therapy changes the topography of your thyroid. And sometimes when you look at it again later, it can look pretty worrisome. And if you're dealing with simply a nodule and you can follow that specific place, that's a little different than trying to track the entire thyroid gland with multiple overlapping nodules and then say, oh no, all this is okay. This is just multinodular residual sort of goiter. And that can be a little bit of a problem. I see myself as being cautious about that. Like I said, I can't say I wouldn't do anybody. I've already done somebody like that. With my level of experience at this point, I would be hesitant to recommend radiofrequency ablation as treatment for a big multinodular goiter with overlapping nodules and diffuse thyroid structural disease. Now, that's not to say in a few years I might change my mind about that. I see that as a safety thing so that we're not inadvertently treating a malignant situation and then we can't really identify it because things are so abnormal on the ultrasound. So my personal sort of limitation at this point is pretty much single nodules that are big and that you can see all of it and that you feel pretty comfortable that the totality of the problem is well understood and confined to an area that you feel like you can completely ablate.
I think that makes sense. Just a few weeks ago, I was involved with the ThyCa has their annual conference, and I got to sit in on a panel discussion where they were talking about RFA for thyroid cancer. It's getting to be a very big topic of discussion in our Facebook group. Patients are very hopeful that they could get their small cancers treated with RFA. And we've had a few who've even gone overseas and had it done that have been, really ecstatic with their results. But one of the questions that I asked in that discussion was to Dr. John Russell, once you've ablated this cancer and it looks different on ultrasound, how can you tell the difference between that and thyroid cancer? And he said, that's a really good question. I'll get back to you on that.
Yeah, I would love to know that question. Therein lies the problem. So you have a tiny little thyroid cancer, a small one, a centimeter. Somebody ablates it. Then after you're done, it looks like thyroid cancer.
Right.
And then the problem is you go, well, is it getting bigger? No, but we know that thyroid cancers can be very small and not change a lot. We used to think that it was very important to know about that the size of a thyroid cancer predicted its sort of behavior. And we know now that that's not true. Little bitty thyroid cancers can be aggressive, and any experienced thyroid surgeon will tell you that. Just because you ablate the primary doesn't always treat the totality of the problem. I mean, it may. One of the reasons that we do surgery and remove thyroid glands is that it creates an environment in which you can use other techniques to track thyroid cancer. The majority of people with thyroid cancer do very well, and they don't have metastasis. And even when they do have metastasis, a lot of times it can be controlled and treated pretty effectively, except for sometimes when it's not that way. The real problem we have is knowing the patient that that's going to be the problem. The thing that predicts how aggressive you need to be with thyroid cancer really isn't its size, it's its biology. And understanding its biology can be very problematic preoperatively. You can get a lot of information about thyroid cancer from needle biopsies, and it can help you predict that sort of aggressiveness. It's in its infancy now. Will there come a time where you do a fine needle aspiration biopsy on a small thyroid nodule that's cancer, and then you analyze its molecular content, and it has a favorable profile biologically for innocuous behavior? Could that person be appropriately treated with radiofrequency ablation? The answer is yeah, probably. But just because you identify a small thyroid cancer that's small and you can stick a needle in it and ablate it, I mean, you don't really understand what you're ablating. You're sort of saying, okay, well, the majority of these are not aggressive, so we're going to kind of just assume yours isn't. So that's sort of my hesitation. Again, it's not that it can't work, and it's not that it's not even a good technique. Don't misunderstand me. I just don't know that there's enough information available for the outcomes about what you can expect from that for me to say, yeah, we should do that. I think it requires more study before I think I could come to a conclusion that it's a good idea. Now, having said that, maybe it is a good idea. For really small thyroid cancers, I mean, but then you'd have to say, well, if it's small enough and you can just ablate it, why don't you just watch it and not do anything to it? That's a different question. And there's some very good Japanese studies about watching and managing small thyroid cancers conservatively. And their follow-up data is actually pretty good for 20 years. The problem with that is if you do something like that on a 42-year-old patient, well, they don't have to live 20 years. That's got to be good for them for 40 years or 45 years. We just don't have the data to know. And not that we ever will. I think your decision making needs to be data driven, not, well, can we do this and get away with it?
Yeah, and I understand the whole concept of active surveillance is preferable to some patients who don't want to have surgery. They don't want to lose their thyroid. But to some patients who the anxiety of knowing it's still in there is too much for them, those are the patients who are really intrigued by RFA. And so I think that once we can figure out a little bit more concrete data, like what you're saying about knowing if this is the right type of cancer for this treatment, I think it'll be a really good alternative for those patients who are just not amenable to the concern of knowing that there's something in there.
Yeah, I agree. I'm not saying that we shouldn't use RFA for thyroid cancer. All I'm saying is we don't have enough data to where we can say you should. I think if a patient is well informed and understand the biology as much as they can from their doctor, they realize the uncertainties, they make their own informed decision, and then they decide that radiofrequency ablation is right for them. Well, I don't really have a problem with that. But I would have a problem if somebody said, oh, you know what? You got thyroid cancer. Well, come on down here and we'll just radiofrequency ablate that and see you later. Oh, yeah, you just pay on the way out. Right? That's sort of my angst about that. Maybe it's not a reasonable angst.
You want a well-informed, well-educated patient.
Yeah.
That's reasonable.
I manage a variety of things in unconventional ways, but always with full understanding and complete transparency on the part of the patient, that they understand that we are departing from what you read about in guidelines published by the American Thyroid Association. We're departing from what maybe other doctors would say would be common practice. But as long as you understand why we're departing from that, what the advantages are, the disadvantages, well, then at the end of the day, I think it's your choice. And if you're comfortable with that, then I can be comfortable with unconventional results. I think at some point in the future, radiofrequency ablation of small thyroid nodules will become an appropriate clinical alternative outside of the person who understands that there's uncertainties. For it to be recommended, I think we have to have a better understanding of what the biology is of small thyroid cancers before we apply it sort of as a standard of care. Now,
I think that's complete.
Not everybody agrees with what I think, so.
I think it's good to have differing opinions, and I think that there's lots of benefit to looking at this from lots of different angles. And that one of the things that's so wonderful for me, I've had the same conversation with people with all kinds of different opinions about this. And I can see it from all of their perspectives. I can see it from your perspective. It's very educational for me to be able to see this. And my goal is to try to help impart this education that I've gained to these patients that are in our Facebook group, because there are a lot of them who are just like, I just want to save my thyroid at any cost. It's, as you have said, and as many doctors have said, this isn't for everyone. But for those that it is for, it does give a lot of hope, and it is exciting. So
Yeah.
I'm glad it's available now, and it's growing in popularity. And as I said, at the time when I had mine done, there were two locations in the country, and now there are close to 100. So,
Oh, wow. Are there really that many?
yeah,
I had no idea. I mean, I think that radiofrequency ablation is a very, very exciting and very good technique for the right patient with the right sort of structural issue. Something we haven't touched base on is the use in people that have sort of hyperactive, smaller nodules that have always required surgery before to deal with them. And this technique would be perfect for many of them. It's crucial, I think, in that setting that you make sure that you get a total ablation. So just a little shrinkage won't work for that. But in smaller nodules, say 2, maybe 3 centimeters, that you really think that you can see it completely and get a total ablation on it, that could be a real great technique for them. I think it's a great technique for benign thyroid disease. I'm in sort of an infancy of doing it. I guess we've probably done around 20 patients now. And so far, everybody's had a very good result.
20 is no small number. I mean, I've talked with doctors who've only done, 5. and given that you've got so many years of surgical experience and the needle biopsy experience and ultrasound experience, I think you're going to be doing a lot more of these.
Yeah, probably so. You're probably right.
Thanks so much for watching. Subscribe and ring that little bell so you don't miss the next video. You can help others tremendously by sharing this content. Never forget to educate yourself and be your own health advocate. Now, watch this next video right here.